Hello, I am Martin Lederman, co-founder of the organization One World, One Vision. Over a decade ago, my associate and I, while on a surgical mission to Belize, founded One World, One Vision in order to train local ophthalmologists and, by doing this, extend our reach. We were successful, and since then, our organization has gone to multiple countries and have demonstrated the success of our ideas. We added anesthesiologists and pediatric intensivists to the mission in order to train local physicians and make the surgical experience of our patients safer. Since then, we have realized that the paradigm of one patient, one student, and one surgeon, while successful, could not begin to address the need. There are tens of millions of children and adults with strabismus and amblyopia. We decided, therefore, to support and to promote a video course in strabismus and amblyopia and approached Dr. Bert Kushner to develop a curriculum and to recruit worldwide experts to give lectures. We stipulated that the course should be translated into multiple languages and to be distributed without cost around the world to eye surgeons. We are particularly grateful to our former patients and friends who have given the financial support to make our dream a reality. We are delighted that Dr. Kushner has accepted the challenge, and we hope you find the lectures both stimulating and educational, and that you share them with your colleagues and your students. And so, without further ado, I give you Dr. Bert Kushner.
Welcome viewers to this One World, One Vision comprehensive course on strabismus. Today's lecture is on dissociated vertical deviation. If you're new to this series, I'm glad you're here. If you are a repeat viewer, I hope that means you have found these other lectures to be satisfactory. And I am totally thrilled today to be introducing our speaker. It's Andrea Molinari, and she is going to be giving the talk on dissociated deviations. She is from Quito, Ecuador. Dr. Molinari is the director of the fellowship program in Pediatric Ophthalmology and Strabismus at the Hospital Metropolitano. She's trained 10 fellows so far, and she's certainly no stranger to the international strabismus community. She is president of the International Strabismus Association, past president of SOPLA, the Latin American Association of Pediatric Ophthalmology, and the Ecuadorean Society of Pediatric Ophthalmology and Strabismus. Currently, she's the International Director at Large from the APOS Board of Directors, and I would say I can't think of anybody who's more knowledgeable about DVD than Dr. Molinari. I have heard her speak on this subject. I think she is knowledgeable, clear, concise, easy to follow, and really the ideal person to be giving this lecture. So, with great pleasure, I turn this over to Dr. Molinari.
Thank you, Bert, for this kind introduction. Hello to everybody. I'm very pleased to be here today and talk about one of the most, in my opinion, fascinating forms of strabismus, which is dissociated vertical deviation. Dissociated vertical deviation is an intermittent deviation of the non-fixing eye that moves upward, lateral, and extorts, as it can be appreciated in this slow motion video. It is different from a conventional vertical deviation because when the fellow eye is occluded, does not show a hypotropia. When can DVD occur? It usually occurs in a patient that is inattentive or daydreaming, as it can be seen in the left video, or in a testing situation when the eye is occluded and the binocular vision is disrupted, as it can be seen in the right video. Since Stevens reported it for the first time in 1895 as alternating vertical strabismus, many names has been given to this disease, but without doubt the most popular one is dissociated vertical deviation, name proposed by Alfred Bielczowski in 1938. Its etiology still remains controversial, and almost as many theories as names have been proposed for this disease. Current concepts focus on either a supranuclear disorder, the appearance of an atavistic subcortical reflex, or mediated by the oblique muscles trying to dampen a latent nystagmus. DVD is not infrequently seen by the physicians who usually treat patients with strabismus. It is especially very, very frequent in patients with infantile isotropia. Some authors even say that DVD is a marker for infantile isotropia. Different authors say that DVD is present in up to 14 to 90% of patients with this disease. In my own experience, in a small series that I collected some years ago of 89 patients with infantile isotropia and a follow-up of at least 1 year, more than half presented dissociated vertical deviation. But only in 13 cases this was a cosmetic problem and surgery was indicated. Despite the frequent association with infantile isotropia, DVD can also occur in other forms of strabismus, like sensory strabismus, especially in those cases with early disruption of the binocular vision, for example, patients with congenital cataracts or malformations of the optic nerve. Interestingly, DVD can also occur in adult patients that previously had a good binocular vision, but the DVD appears when they lost this binocular vision. DVD can also be associated to exotropia, more frequently in consecutive exotropia. But in these cases, DHD has to be ruled out. Cindy Pritchard found an incidence of 47% in her series of exotropic patients, most of them without latent nystagmus. DVD has special clinical features. Among them, it's a mixed vertical, horizontal, and torsional movement in the non-fixing eye that occurs when the patient is inattentive, daydreaming, or in a testing situation. It is usually intermittent and manifesting with a variable magnitude. It can be constant in very amblyopic eyes, and in these cases, it can be unilateral, but it is usually bilateral and asymmetric. Latent nystagmus with a horizontal and cyclovertical component is present in half of the cases. Horizontal incomitants can be present, especially when associated with oblique muscle dysfunction. Measurements can be variable when measured in different days. Fusion is usually poor and suppression can be present. DVD is more manifest at distance than at near fixation, and therefore it is also always more recommendable to measure it with a distance target. Anomalous head posture is present in up to 35% of patients with DVD in the form of a head tilt or a head turn. And the purpose of this anomalous head posture is to control the deviation. Direct tilt is when the head is tilted to the fixing eye, and inverse tilt is it when it is tilted to the non-fixing eye, but it is also called typical or atypical anomalous head posture. And this is better described or more in detail in the lecture on vertical strabismus of this same series. DVD can be present before 12 months of age, but it is more commonly noticed after the first year of life, usually after operating the children for congenital esotropia. For example, like in this case, where you can see a child with congenital esotropia that got a very good alignment after the bilateral recession of the medial recti, and a couple of months later, he develops the DVD. For the experienced examiner, diagnosing DVD is not difficult. The slow vertical deviation appearing in the non-fixing eye with not an hypotropia in the fellow eye is pathognomonic for DVD. But there are several tests that can be used for diagnose this disease, and we're going to describe all of them: the prism undercover test, the reverse fixation test, the red glass test, and the Posner maneuver. The prism undercover test is a very good test to diagnose DVD, but also to measure the magnitude of the DVD. And the way to perform it is the following. First, we're going to examine the right eye, and we cover the right eye with the occluder, and we look at the magnitude of the deviation. Then we place a prism that supposedly will neutralize that deviation between the cover and the eye. We leave the cover at least 5-10 seconds because this is a slow deviation. And then we shift the occluder to the left eye. And look what happens to the examined eye. If the eye does not move, that means this is the prism that neutralizes the deviation. And here you can see it with a patient. We cover the right eye and you see the DVD. We place the prism and then we cover the right eye for 5-10 seconds and shift the occluder to the other eye and see what happens with the right eye. You will notice that the eye makes a horizontal movement because the patient has also a DHD, but does not move vertically. The reverse fixation test was first described by Matthew and co-authors to diagnose DVD, but is more commonly used to diagnose DHD. So this is the way it is performed. We place, again, a prism between the occluder and the eye that neutralizes the horizontal deviation. And then we move the occluder to the other eye. Then we move the occluder back to the first eye and see what happens with the unoccluded eye. If the eye does not move, that means this is a conventional deviation. But if the eye makes a refixation, this means it is a dissociated deviation. The red glass test is also very useful, especially with small DVDs that cannot be very well recognized. So when a white light is shown to the patient, in a DVD, she always prefers seeing the red image below the white image, no matter in which eye the red glass is placed. In patients with non-dissociated vertical deviation, the red image is seen below the white image when the red glass is placed in front of the hypertropic eye and above the white image when it is placed in front of the hypotropic eye. The Posner maneuver is also a very interesting maneuver to diagnose DVD, although it does not quantify the magnitude of the deviation. Look, for example, this case. This is a girl that is aphakic on her right eye, and this right eye is amblyopic. She has 20/70 visual acuity in her right eye and 20/25 in her left eye. So we look at video now, and we occlude the video with translucent occluder. You see the DVD showing up, and then we occlude the other eye with the same translucent occluder, and you see the right eye coming down. This is called the Posner maneuver, and is very characteristic for DVD. Treatment of DVD is always surgical when indicated, but before indicating a surgical procedure, it is very important to encourage any possible fusion by providing optimal optical correction and treating amblyopia if it is present, since a blurred image will make that a latent deviation becomes manifest. This is why giving a correct optical prescription will compensate many of the DVDs. Like, for example, in this case, is a patient with congenital esotropia, as you can see on the left picture, that was very well aligned after surgery. And with the glasses, the deviation was completely compensated. Even 10 years after surgery, you can notice that without the glasses, there is a small DVD on her right eye, but that never decompensate when she has her glasses on. When are we going to indicate a surgery in our patients with DVD? There are three specific situations when we indicate a surgical treatment in our patients with DVD. Patients with a DVD that is large and decompensates very frequently, resulting in a cosmetic problem. Patients that are at risk of developing or worsening pre-existing amblyopia when the deviation is frequent enough to produce intense suppression of the deviated eye. And patients who adopt a significant anomalous head posture to control the magnitude of the DVD. It is important to tell the patients that the head posture might not disappear with a surgical treatment, but it will most certainly improve. In order to plan for the best surgical strategy, there are different clinical characteristics that we have to notice before planning our surgery. Visual acuity, magnitude of the deviation, symmetry, presence of non-dissociated vertical deviation, horizontal incompetency, and presence of other dissociated deviations. Determining the visual acuity is crucial when you have patients like this one with an apparent unilateral DVD. And different authors have determined different visual acuity limits in order to perform unilateral surgery. Since DVD is most commonly bilateral, it is important to be sure, if you're planning to perform a unilateral procedure, that that eye will never be preferred for fixation. Establishing the magnitude of the deviation is also very important in order for planning the best surgical strategy. It's not the same if we do the surgery on a patient with a small, moderate, or large DVD. And the fact that the measurement of the deviation is so variable shouldn't discourage the surgeon in trying to obtain the most accurate measurement. DVD is very asymmetric, and usually it is so asymmetric that it seems unilateral. For example, like in this case, this boy came to my office, the parents complaining of the deviation on his right eye, where he had a very notorious DVD that I measured of 20 prism diopters. He also had a DHD, very small on his right eye of only 10 prism diopters, and a little bit larger on his left eye of 15 prism diopters of deviation. I really examined him for a long time, and I could not elicit a vertical deviation on his left eye. And even if the visual acuity was 20/20 in both eyes, I decided to perform a superior rectus recession of 6 millimeters only in his right eye, and a bilateral lateral rectus recession of 5 millimeters on his right eye and 7 millimeters on his left eye. The second day post-operative, he had a DVD on his left eye. And only after recessing the left superior rectus 5 millimeters, the result was satisfactory. This is not very frequent, but in some cases, you can also find non-dissociated vertical deviation associated with the dissociated vertical deviation. Like, for example, in this case, you can notice in the left picture that this patient has a significant DVD in his right eye. And if you look at the video, you will see that when the left eye is uncovered, the left eye, who has also a small DVD, makes an upward movement, which, as we said in the beginning, non-dissociated vertical deviation will have a hypotropia when the eye is occluded, like in this case. But this patient has also DVD in his left eye and in his right eye. In the right eye, it is more noticeable. If you look at this other video on your right, you will see that there is a very significant horizontal incompetency, much larger vertical deviation in adduction and less vertical deviation in abduction, which is more noticeable in his right eye, although it is also present in his left eye because he also has an inferior oblique overaction in his left eye. He has an asymmetric DVD and an asymmetric overaction of both inferior obliques. And here in this next slide, you will see when he fixes with his right eye, the left eye has a small hypotropia. And if we look at the video, you will see that there is also a V pattern, which is not very big, but it is present. So DVD usually has a slight incompetency, but this horizontal incompetency is much more pronounced when there is oblique dysfunction also associated to the DVD. When the DVD is associated with inferior oblique overaction, the hypertropia will be larger in adduction. The patient will also have a V pattern, as the patient we just saw before, and the patient will also have a fundus extorsion. When the DVD is associated with a superior oblique overaction, the patient will show a larger hypertropia in abduction with an A pattern and fundus intorsion. A hypertropia larger in abduction can also be seen in patients with DVD and associated superior rectus overaction contracture syndrome. But in these cases, the patient will not have an A pattern or a fundus intorsion, but will present a positive Bielchowski head tilt test. There are several surgical procedures that have been advocated for DVD. Among them, superior rectus recessions, large recessions for bilateral cases, moderate recessions when only one eye is going to be operated on, inferior oblique anterior transposition, graded recessions augmented by resections, nasal anterior transposition, plication or resection of the inferior rectus, small recession of superior rectus with posterior fixation or with wide splitting of the muscle, weakening of the foreoblique muscles, and recession of both inferior recti. The existence of so many procedures for treating this disease reflects the fact that none are completely satisfactory. The best surgical result that we can obtain in these patients is improving the DVD and improving also the control of the DVD. Superior rectus recessions are by far, I would say, the most popular procedure for treating patients with DVD, especially when there is no inferior oblique overaction. And the amount of the recession of the superior rectus usually is larger than the amount that we usually performed in conventional vertical deviations. There are different tables from different authors, and these are the numbers I usually utilize. When we have a DVD up to 10 diopters, I use 7 millimeters. In a moderate DVD with 10 to 20 diopters, 8 to 10 millimeters, and more than 20 diopters, 11 to 14 millimeters. Remember that when you are doing a unilateral superior rectus recession, the recession has to be much smaller, up to 6, at the most 7 millimeters. When performing very large superior rectus recessions, you will find it not very easy to place a fixed suture so far behind. And this is why hangback sutures can be useful. Julio Prieto Diaz recommends using hangback sutures, not only because it is easier, but also because when you perform fixed sutures, let's say 12 to 14 millimeters back from the insertion, your sutures will be placed in the path of the superior oblique tendon. And when the eye comes back to the primary position after placing the suture, this will interfere with the tendon, with the superior oblique tendon. I prefer to use fixed sutures. So what I do is I usually place a fixed suture in the temporal border and an hemi-hangback in the nasal border. In order to get the weakening effect you want for your superior rectus recession, it is very important to dissect the muscle thoroughly from the connective tissue that surrounds the muscle. And this includes the check ligaments, the intermuscular membrane, and the connective tissue that connects the superior rectus with the superior oblique, which is called the frenulum. Superior rectus recession has also been described associated with posterior fixation. This is the original drawing from the paper from Cupers, who described the Faden procedure, and it was described in a superior rectus. It is usually combined with small recessions up to 5 millimeters, and the posterior non-absorbable suture has to be placed at least 12 to 15 millimeters from the muscle insertion. And this is why good assistance is needed when performing this procedure. Another procedure that allows you to recess the superior rectus not so far back is the wide split of the muscle. And this is a video very kindly provided to me by Dr. Pradeep Sharma from New Delhi, where you see that he recesses only 6.5 millimeters and splits the muscle, obtaining a good result for a large DVD. Inferior oblique anterior transposition is another very popular procedure for treating DVD, especially those cases that are associated with inferior oblique overaction. This technique was first proposed by Alan Scott in 1978, but it was first described by Elliott and Nanking for the treatment of DVD. After that, many other authors recommended that it's used for the treatment of this disease. The anterior transposition can be augmented by resecting the muscle, and it can also be graded. Anterior and nasal transposition of this muscle has also been advocated for treatment of this disease, as you can see in this paper. But usually the success rate is better when it is a moderate DVD, not with very large DVDs. A very important complication of this procedure is the anti-elevation syndrome described by Dr. Kushner. And this is very well described in the presentation on vertical strabismus of the same series. A video of this index case can also be seen in this presentation. Another procedure is inferior rectus plication or resection, and this has been advocated as a primary procedure for DVD by Mexican authors, but usually it is used as a secondary procedure for recurrence or residual DVD. The plication or resection should be moderate, up to 5 millimeters, in order to avoid restriction of elevation and narrowing of the palpebral fissure. Recessing both inferior recti was also described by a Mexican strabismologist, Dr. David Romero Apis, with the following hypothesis. By recessing both inferior recti, the patient needs having more innervation to the inferior recti in order to keep the eyes in primary position. And by Sherrington's law, this will produce inhibition of the superior recti and therefore controlling a DVD. But this procedure is especially useful in those cases where the DVD diminish when the DVD is observed with a patient with a chin-up posture, as you can see in this video, which is called the Castellanos maneuver. If the DVD diminishes in comparison with the DVD present in primary position, then this procedure might be useful. Weakening of the 4 oblique muscles is a procedure described for DVD by Dr. David Guyton, since with the hypothesis that DVD is produced by the action of the oblique muscles by trying to dampen the latent nystagmus. And many other authors have tried this procedure and have found good results. But in order for this technique to work, the DVD has to be symmetric, and the superior oblique overaction has to be also symmetric with a large A pattern. So far we have described the different clinical features in DVD. We have seen the different tests that can be used to diagnose this disease, and which are the different different surgical techniques that have been described for treating this condition. But DVD can manifest in different clinical scenarios, and the surgical strategy has to be adjusted accordingly. So now we're going to see different cases and discuss the different surgical strategy for each one. For example, patients with symmetric or asymmetric DVD and with no oblique dysfunction, asymmetric bilateral recession or asymmetric bilateral recession in cases of asymmetric DVD is a very good approach to improve the patient's condition. Patients with very asymmetric DVD, with deep amblyopia and no overaction of inferior oblique, like this patient that was aphakic on his left eye, a unilateral moderate superior rectus recession can be done. But you always have to be sure that when you perform a unilateral surgery, that this eye will never be preferred for fixation. Patients with DVD and inferior oblique overaction, like this case of a patient that had a congenital esotropia and got a good alignment with a bimedial recession, but afterwards developed inferior oblique overaction and DVD, inferior oblique anterior transposition of both eyes is a good procedure, and a long-standing also. You can see the same patients 20 years after. He's still very well aligned and with no inferior oblique overaction and no DVD. But when you have patients with very large DVDs, over 20 prism diopters, inferior oblique anterior transposition will not be enough to correct the problem, and you have to add a superior rectus recession. But be aware that superior rectus and inferior oblique are both the elevators of the eyes. So you have to be very careful when recessing the superior rectus, and because you cannot make a very large recession. You have to do a small recession in order not to cripple the elevation of the eye. In a patient with unilateral DVD and poor vision in the non-fixing eye, like this patient who had a dragging of her fovea, a unilateral inferior oblique anterior transposition can be done. And here you can see the patient 3 years post-op. She has a very good alignment, no DVD, but you might notice a small limitation of the elevation of the left eye, which is the eye where the surgical procedure was done. Patient with unilateral DVD and poor vision in the non-fixing eye, but bilateral inferior oblique overaction and V pattern, like in this patient with a morning glory syndrome in her right eye, a bilateral inferior oblique anterior transposition was indicated. And here you can see the patient 4.5 years post-op. As you can see in the lower image, the DVD in her right eye was completely controlled. And in the superior picture, you can recognize that when the fixing eye is covered with a translucent occluder or a regular occluder, you will notice a small downward deviation of the other eye, which is called the Heinemann-Bielczowski phenomenon, which is pathognomonic for DVD. Patients with DVD and A pattern and superior oblique overaction, like this patient that had an infantile esotropia, was very well aligned, and many years later developed the DVD and a superior oblique overaction, are very particular cases. If the A pattern is up to 10 prism diopter, a bilateral superior rectus recession is enough to correct the DVD and the A pattern. If the A pattern is moderate, 10 to 20 prism diopter, you have to add to the bilateral superior rectus recession a posterior superior oblique tenectomy. When the A pattern is big, is larger, more than 20 prism diopter, you have to add to the bilateral superior rectus recession a complete superior oblique tenectomy. Other authors, and if the DVD is symmetric, would prefer a 4 oblique muscle weakening procedure. And finally, patients with decompensated DVD after large bilateral superior rectus recession without inferior oblique overaction, like this case that is a patient that was aphakic and had DVD in both eyes. We did a large bilateral superior rectus recession as the first procedure, but still after that procedure, his left DVD decompensated very frequently. And in this case, we elected to perform application of the left inferior rectus with a good cosmetical result. So to conclude, as you have seen, there are many different surgical options to treat our patients with DVD. You have to be very careful in recommending a surgical procedure for your patient with DVD and explain that very rarely DVD will disappear. It can be improved, but it is very uncommon that it will disappear. And examine your patient carefully in order to choose for the most appropriate surgical plan. With this, I conclude my presentation, and I thank you all for your kind attention today.
Well, thank you, Andrea. That was, as expected, that was just fabulous. You covered it all. I loved the animated graphics you have in PowerPoint. I'm going to someday have to ask you how you created them. But very clear recommendations for how to treat the multiple different patterns that DVD presents with. Just one or two questions or comments, if I may. In my experience, the most common presentation for DVD is for it to be bilateral but asymmetric, but also, assuming there's no amblyopia or anything like that, it's intermittently not constant, intermittently manifest in one eye, and only latent in the other eye. Not always. Do you, when you're recording notes for your office records on patients, do you indicate if DVD is latent versus intermittently manifest or rarely constantly manifest? And would that influence your treatment?
Yes, of course, I do that. And I also try to grade the decompensation, how often the DVD gets decompensated. And you're right, that's also have been my experience. Patients with very asymmetric DVD, usually associated with some type of amblyopia, and very asymmetric. And yes, I record the difference of the manifestation of the DVD in each eye.
The other question or comment that I have, I absolutely agree the Prism undercover test is the gold standard for measuring a DVD. And again, I just love the graphics on how you show that. But I find that many patients always have a redress at the end. I never get to the point that there's no movement at all. It may move down a little and back up, or up a little and back down. And I have to kind of estimate, is that up movement the same as the down movement? Is that your experience? And do you have any tips on how to minimize that redress?
Yes, unfortunately, that's also my experience, because that makes the measurement of the deviation much difficult, right? So, and also it's difficult to explain the fellows and the residents how to measure the DVD because of this refixation movements, or that the eye does not stay still. And also the difficulty is because, as you could see in the video that I showed, that it is very commonly associated with other dissociated deviations like DHD. So you might neutralize the vertical one, but then you have also the horizontal one. And that makes the deviation more difficult. The measurement, sorry, more difficult. So what I do is I usually try to measure the largest deviation first, and then try to measure the other deviation, the horizontal. Let's say he has a large vertical deviation and a small DHD. I measure first the vertical deviation. I try to compensate that as better as possible. But as you say, since the measurement is also variable, you might get different measurements. The important thing is to estimate the measurement. You will not have, like in other types of strabismus, where you can say this patient has 15 prism diopters of deviation. In DVD, I would say it's an estimate. But you can say it's a large deviation when it's around 20, or it's a moderate deviation when it's around 15, or a small deviation when it is less than 10.
Excellent answer to that question, and I really appreciate your comments on it. That was terrific. So I think that wraps up our session today. Again, I thank the viewers for tuning in. I certainly thank Andrea for making time for this wonderful presentation. And as I said, for the viewers, if you enjoyed this, I hope you'll tune in to all the other lectures in this series. And with that, I'll wish you, depending on where you're viewing from and when, either good night, good afternoon, or good morning.
In bringing you this video course, there are many thank yous. Thank you for viewing the video course on strabismus. We hope you found it stimulating and educational, and that you share its insight with others. We at One World, One Vision extend our heartfelt thanks to the lecturers who shared their years of study to make the video course worthwhile. And of course, to Bert Kushner for taking on the burden, happily we hope, of development and moderating. We also thank the Board of Directors for their continued guidance. We thank our donors for their financial support that made this video course possible. An enormous thank you to the video team of Sweet Sadie for their extraordinary efforts to make the course, both visually and auditorially, extraordinary. and for their technical guidance of lecturers. Thank you, Rachel, Tim, Eddie, and Bill. If you are interested in learning more about what we do, go to our website, www.oneworldonevision.org. And finally, if you have comments or thoughts or ideas, you can email me at owov2020@gmail.com. Goodbye.